So this month marks 2 years since COVID-19 first hit South African shores. In fact, the healthcare industry is undoubtedly one that's been among the worst affected by the pandemic. Medical aids have had to adjust their plans in order to accommodate things like hospital stays, COVID-19 tests, and vaccination costs, amongst a long list of other things. So how much exactly did COVID-19 tally up financially from medical aid schemes perspectives? Well, Managing Director at Board of Healthcare Funders, Dr Katlego Mothudi, is our guest on this. The doctor is us via our video link this morning, and it's great to see you, Doc. It's great to also have you on the program. Is there a way of being able to tally up how much COVID-19 has essentially cost the medical healthcare sector?
Good morning, Ayanda, and thanks for having us. We are able to see the impact. Fortunately, we have an annual report from the Council for Medical Schemes. We are in the position to indicate that for 2020, medical scheme paid, I think, just over 3.3 billion rand towards costs for COVID-19. The figures for 2021 will only be released later, and this would be costs that would also now include what the schemes have paid for vaccines as well.
So this 3 billion rand for 2020, I mean, help us better place it. How does it fare, for instance, when compared to claims for other healthcare needs?
The 3.3 billion is actually the fourth highest in terms of other conditions. It is preceded by things like general emergencies, pregnancy-related costs, mental health claims, including depression and bipolar. So it is in the top 5 of the cost drivers for medical schemes.
That's very interesting. So you say issues to do with mental health essentially cost more. Does that mean there's been an uptick? Or let me ask it this way. Is there a correlation between claims for something like mental health and, the pandemic?
So let me take a step back.
Right.
The other 3 elements that I mentioned have always featured in the top 5. And your question is right. There may be a correlation. It may be difficult now to actually spell out what has been linked specifically to COVID. I must, however, say that when we looked at the claims pattern for 2020, initially there was actually quite a big dip in terms of claims. You would remember that people became averse to consulting. A lot of, in fact, quite a number of practitioners reported as much as an 80% drop in consultations. By May, hospital groups had reported something close to 60% reduction in claims. So while we say that COVID ranks as one of the top claims for schemes, it has had other impacts on the medical aid. The total annual spend for schemes for the preceding year was about 185 billion rand. In 2020, this dropped by about, I think, 7 billion rand to 178. So while COVID does rank as a cost driver, there are other, I would say, unintended consequences that happen as a result of a change in behavior of beneficiaries in terms of health-seeking behavior.
What are the implications for the business model, do you think, specifically for medical aid schemes because of this change in behavior? And it's kind of a weird question to ask because we can't really see what the future holds, right? I mean, for all we know, in a year's time, we might be back to life pre-COVID-19. But in the event that that does change, are there conversations around re-looking at what, for instance, medical aid schemes prioritize in a context of a global health crisis?
Let me answer that in a few parts. So for COVID specifically, there were other unintended consequences. The health-seeking behavior also meant that people who were supposed to go for their regular checkups for chronic illnesses delayed this. And there were quite a number of also needed surgeries, while not deemed to be urgent, were put on the back burner. The concern is around those who did not turn up or delayed treatment for maybe their hypertension, etc. We are concerned that there might be complications later on as a result of people not having taken that treatment. You may remember as well that in the public sector, quite early on, there were reports that some 10,000 people in Gauteng alone did not turn up for collection of their HIV medicine. So there are issues from a clinical perspective. From an access perspective, there were some positives. Because of the challenge of going to practitioners, we saw an improvement in terms of technological advancements. One of those is in terms of telehealth. The HPCSA made adjustments to their policies and then allowed for virtual consultations to be possible even for first-time consultations. We think that is a trend that will continue, and we've observed that to be also worldwide. The other one that I just want to mention is that because of the capacity issues in hospitals, there were a number of innovations where people could be virtually admitted, like at home, and could be remotely monitored. Now, we think that these are good advancements in the main, and it will do good for the industry to actually embrace, and also for technology advancements to keep up with the needs of the health citizen.
Sure. All very fascinating indeed. I imagine there are also differences that we're noticing in so far as where people actually are in the country. Is that the case? I mean, are you finding that depending on where you live, you've responded differently to the pandemic and have interacted differently with medical aid schemes?
Yeah, it all talks to access, and maybe I think another question possibly behind that is where the challenges compared to maybe state and non-state facilities.
Right.
While government made sure that the protocols for treatment of COVID were the same, maybe from a financial point of view, there was maybe no difference because everything that you could access was covered. But as I've alluded to, there may have been advantages in the medical scheme environment, so in that you could access health virtually because the structures are in place. Now, whether you are in a rural place or an urban area, that would greatly impact your access and also your access to these particular technologies. You'd also be aware that a lot of the contracting that was happening between the various sectors was done on a provincial basis. This meant that the agility of the various provinces and their various capacities would then have an impact on access to healthcare. So there may have been some differences based on your regional disposition.
All very fascinating trends indeed. Thanks very much indeed for breaking it down for us as well. Appreciate your time on the AM report. Dr. Katlego Mothudi is Managing Director with the Board of Healthcare Funders. Once again, Doc, thanks very much.